Sollis. Better insights for better outcomes. This session was recorded live at our Advances in Population Health Management workshop in London, November 2018.
It gives me great pleasure to invite to the stage Jeremy Taylor. Jeremy is a charity leader and chief executive of an organisation called National Voices, and he'll hate me for saying this, but I'm going to say it anyway. Jeremy, building from the James story, this is the voice of the people.
Thank you, Nigel. A lovely, another keynote speech. It's very weird standing here behind all this equipment. Another keynote speech, another bald bloke to deliver it. So the kind of symmetry with the morning session. And I just want to start with a slightly adapted Shakespeare quote that occurred to me as I was sitting here in the morning. Now are the winter pressures of our discontent made glorious summer by this long-term plan, if we ever get to see the long-term plan. So that's the Shakespeare. Thank you very much for your kind introduction. I've deliberately called this a kind of lay perspective. I think it's slightly arrogant to say that this is a patient voice. It's a view. It's an emerging view. It's a personal view. It's based on a lot of the work the National Voices has done, and I'll explain a bit about our work. It's not a case study of a particular intervention in a particular place. It's kind of some general thoughts that hopefully will frame the discussion for this afternoon and reflect on some of the material from this morning. It's heavily influenced by the work of my fantastic policy director, Don Redding, who was here earlier, but he may have sloped off. I don't know if he's still here. And also, indeed, in turn, by lots of conversations we've had with some of the experts and leading lights in population health management, including Steve Laitner, and including Nigel and Sollis. We freely borrow and plagiarise from other people's ideas and try and present back a view. So, see what you mean. It's not...
It is up on the screen.
Oh, it is? Oh, OK, this is really... OK, I'm going to have to peer. So there you go, National Voices. I can't read my own slides. So we've been going for 10 years. It's our 10th anniversary year. And we're about essentially three things that actually, at their best, are very mutually reinforcing. One is about person-centred care, changing the model of care for people with illness and long-term conditions and disabilities. We've been, I think, a very powerful voice, I hope so, as part of a broader movement which has been about changing the model of care away from a reactive, episodic, medicalised, paternalistic model of care to one that is collaborative, that engages the patient, that is inclusive, and that is holistic. And we think that's a model of care that isn't just for the top 3 to 5% most complex cases, and perhaps we're going to have a bit of discussion about that. So I think we've always tended to think that if you want to change the culture of care, you need to be doing it at a slightly broader basis than just the most complex cases. We're also passionate about changing the model of engagement. Patient to public involvement, as it's sometimes called, it's a slightly old-fashioned term in my view, changing the way the system relates to the citizen at an individual level and a collective level. And that's part and parcel of creating a new model of care. And the third element, and this is the kind of where the kind of the vested interest comes in, because we're an umbrella of charities. So we see ourselves as a voice for the voluntary and community sector, and the very important role that it plays as a partner, as a part of, as a piece of the jigsaw in the health and care landscape. So that's us, and that gives you a bit of a flavour of, I guess, where I'm going to be coming from in this presentation. This is what we do. We kind of try and influence policy and practice. When we started life, we were very focused on the then Department of Health, but in the last few years we've kind of broadened our outlook, partly as a result of realising that it's not enough to influence policy, because policy doesn't necessarily change practice. Practice is about commissioning behaviour, it's about levers and incentives, it's about professional culture, it's about the behaviour and motivations of individuals, both in the system and patients, it's about the role of the voluntary sector. So we've become much more interested in practice and how you turn a vision of a good model of care into practice on the ground. Yes, this is a world, the population health management thing is a world full of jargon, and we're always very sensitive to jargon, partly because, you know, we are there to provide a kind of lay and patient perspective on things. And a lot of this stuff can, at its worst, be quite alienating and baffling. I'm sorry, I'm going to have to peer because I didn't print off my slides. Yeah. Well, you know, all this stuff is quite technocratic. And I think there are some real problems about population health management from a kind of conceptual point of view. What is the population? What is a population? And what are you trying to do with your population? What are your goals and objectives? Because there are different goals and objectives. And population health management, however sophisticated it is, however good the analytics are, however good the data are, is only a servant of a purpose. And so there's something about being clear about the purposes. And actually, as it happens, and Nigel's already referred to the King's Fund report that came out only yesterday, I kind of buy into their vision of population health management, which is, you know, what is this about? It's about addressing health inequalities. It's about addressing the slowdown in the increase in life expectancy, in healthy life expectancy. But I think each area has the ability, and I think probably the kind of moral requirement, to develop its own set of priorities for what needs to happen in this particular area for the population. And the word population itself, I think, is a slightly, you know, I don't think people relate to that. People relate to people and communities, but a population sounds very abstract. So I think it's incredibly important to be clear about the objectives that underpin the use of the tools which will then follow. Then how are you going to generate the intelligence to find out what matters to your population? Data analytics, the sophisticated and clever stuff that Sollis does has got to be part of that, but it's probably not all of it. And some of what I'm going to go on to say will be some ideas about how the analytical approach may miss out important things, and therefore it can't be the sole source of intelligence. And then finally, how are you going to act on this intelligence? Is it going to be a fantastic kind of data analysis job that doesn't actually change anything? So for me, the proof of the pudding is, does population health management and its tools and techniques and approaches actually lead to improved health outcomes, to improvements against the objectives that have been set for a particular area? And I think there's something about who sets those objectives and what role do people and communities in a particular place have in having a say about what the objectives should be. Is population health management a top-down exercise, or is it something that engages the whole population? And if you look at the history of SDPs, where there was a kind of noble but not very well followed through intent for the SDP plans, the original ones, to be co-produced with their local communities, that came into direct conflict with the other injunction, which was you can't talk about these plans until you've eyeballed Simon Stevens and, at that point, Jim Mackey. And the kind of top-downness won out over the kind of engagement bit. And as a result, an awful lot of people were really quite pissed off that they hadn't had a say in these secret plans as they became seen. And there's another chance now with a new wave of SDP plans that will follow from the long-term plan. Can local footprint areas get it better this time? They're going to have the same problem, I think, as they had previously, which is many of the decisions will already have been made at national level, but that still leaves quite a lot to play for. So can there be a better conversation between local systems and local populations about what are we trying to do here before launching into all the kind of technocratic stuff? So those are my thoughts about population health management. I'll peer around for the next one. Well, look, me and Steve, we've got a lot in common. We've got no hair, and we've both come up with either microscope or telescope visuals. The whole language and ethos of population health management can sometimes feel like that. And I think Steve has already kind of made the point that may not be the right way. You may be looking through the wrong end of the telescope or microscope or whatever instrument you want to insert. But also there's a sense of doing things to people rather than it being more of a participative enterprise. So personally, I'd like to see more of this and a bit less of the microscope. So, segmentation. When people talk about segmentation, I think of segments of body parts. I do, that's the first image that comes to mind. I don't like segmentation as a word, and I get why it is important and perhaps necessary. But at its worst, it's dividing up your population into little bits of chicken. And did they have any say in that? And how did they feel about it? So I'm not that keen on segmentation as a word. I'm not that keen on stratification either. I think of strata. You know, what if you're the bottom layer in in those rocks? And what if you don't like being in the bottom layer? What if you want to be the top layer? What if somebody else decided where they were going to lay you? I'm labouring my points, but I just found those visuals and I thought I've got to put them in my presentation. And when we think about the segments that are commonly used, and I know that I'm going to be riding roughshod over a whole load more sophisticated analysis and thought than I'm doing justice to here, but these are typically about place-based factors, demographic factors, illness factors. I think Steve made a very good point that individual diseases may not be the most effective and efficient way of dividing up your population, not least because of the challenge of multimorbidity, which I think is a challenge in all kinds of ways. It's a challenge, the word is crap, and I shouldn't really use it. It's another of those horrible technocratic, jargonistic words, having lots of things the matter with you. But it's a challenge to our conceptual frameworks, and it's a challenge to delivering good care. And other things being equal, my elevator pitch on multimorbidity is the only way forward is person-centred care working with the preferences and goals of the individual, because you cannot second-guess the trade-offs that they will make as between different conditions and what actually really matters to them in their life. So for all those reasons, the kind of segmentation approach and stratification approach that comes from analytics, I think, is in danger of missing the point. My personal bugbear is that when we talk about risk, it sometimes feels as though, for understandable reasons, a lot of the risk that people are worried about is the risk of people causing expensive demands on the system and therefore wanting to manage that demand away. So the risk is of the risk of an expensive incident that might be avoidable. And there are good reasons, very good reasons, which align pretty well with what would matter to the patient, but not necessarily entirely aligned. And so there is a danger that if you focus on how can we keep people out of the expensive bits, we're actually not delivering good care. And I think there are lots of examples that we can all think of where the desire to divert people, get them out of the expensive bits of the system, doesn't necessarily work for them and might lead to greater expense later on. So I think there are limitations to the kind of categories that we create through segmentation, stratification. If I'd had a bit more time, I might have put up a slide with kind of gently taking the mickey out of impactability, and I would have had probably a kind of Monty Python type giant boot stamping on somebody. But I don't need to labour that point. So human difference is more complicated and sophisticated and nuanced, and not necessarily well captured by the kind of analytical approach of population segmentation and stratification. However, the challenge is, can the clever data analytics people get better at capturing some of this? Can we capture preference? Because preference is really important. If we don't understand patient and service user preference, then we're missing a really important part of the piece. I'll come back to that a bit later. Resilience. You know, some people are more resilient than others. Some people are more frail than others. How do we get us an understanding of how, you know, there are some people who have 3 or 4 multiple long-term conditions who just get on with life and they're in work and they don't bother anybody, and there are other people with 2 or 3 or 4 long-term conditions who are need help and are banging in and out of hospital, and they may belong to a similar cohort. Attitudes. are really important, and that links to the notion of patient activation. It's not a term I particularly like because it falls into the same sort of trap as some of the other jargonistic words that I've been discussing. But at the heart of the idea and the theory and practice of patient activation is the notion that people have a certain bank of knowledge, skills and confidence to manage their health and to manage long-term conditions if they have long-term conditions, and that the level of knowledge, skills and confidence can be influenced and increased, and that if you increase it, actually people end up with better health and are better able to cope, and there are interventions that enable you to increase the activation, so it's worth doing. So for me, there's a big thing around can activation, the measures around that, the interventions that lead to greater activation, and an understanding of how activated your local population might be, can that play into the population health management data analytics as well? We talked, I mean, the video of James is a very touching reminder that social isolation is a big health and moral issue. It's a societal issue that we should all worry about because of its health consequences, because of its contribution to much misery and suffering. And social connectedness is a really vital ingredient in supporting health and well-being and coping. Can we get a better understanding of who the people are in our communities who are very isolated and need help? So for me, these more subtle aspects of human variation and difference are really important. I've deliberately not called them segments because I don't like the word segment, but can they be more wholeheartedly embraced by the clever people who do the data, so we can get a more rich and sophisticated understanding of the communities that we're serving. And I genuinely don't know the answer to that question. I'm hoping that in this room there are people who are saying, yeah, we're already doing this. And I did miss, sadly, the session just before lunch. So some of what I've covered may already have been beautifully exemplified in some of the case examples, in which case I'm both sorry I missed it and encouraged. So where does the notion of population and population health management meet people and the individual? I don't have any definitive prescriptions here. These are emerging thoughts and they are personal thoughts, but they are based on the work the National Voices does. So, yes. So the first part for me would be something about better data. And so some of this is about, can we have better categories and try and get data among the categories that I've just been talking about. Some of it is about, I don't think the NHS does this well enough. There's lots of data out there, not just about people, but from people. Data about people's complaints, data about people's experiences of care, data about people's clinical outcomes, the friends and family test, for what it's worth, is a data feed. Do we sufficiently use and mine the data not only about people, but the data from people? It's just a question. And I don't know the answer to it, but my sense is that overall, this is an area of relative underperformance for the NHS, probably for a variety of reasons. I think that advances in data sharing, electronic health records that can be properly shared, the digital revolution that Matt Hancock is reminding of us of constantly, which is actually starting to catch up with the policy aspirations that were set 20 years ago, gives us new opportunities, one of which is actually to take data from individual care records and aggregate it and analyse it and get a much richer understanding of the patterns of preference and the patterns of experience, the experiences of care and the experiences of living with different conditions. My sense is, and I'm not an expert on data analytics, or in fact I'm not an expert on anything, that's the great advantage of being Chief Executive of National Voices, you're a jack of all trades and master of none, par excellence. But my sense is that we are going to very soon have some real opportunities to get better at mining and understanding of patient preference. And if we can get to a situation where health and care records also are the place where people can, the place that people can use as part of their self-management programme, where they can record their own preferences and care plans and action against those plans, you'll have even richer data. And people much cleverer than I could probably find a way of getting hold of that data and doing something with it. Alongside that comes a whole load of issues about the ethics and public acceptability of data sharing and how we use that. That's not a topic for today, but it is important context. And some of the work that National Voices is involved in with one of the LACRs, the Local Healthcare Record Exemplar pilots, is precisely to do a stream of work on, if we're doing all this new clever stuff with sharing data, let's make sure that we're having a conversation with local communities about what they think about it and what's going to happen and how they can be involved in that process. So, and avoiding rigidity in the conceptual framework that we use, I think that's incredibly important. I think the framework that Steve put up, the kind of 9 3x3 matrix, I think that has the advantage of relative simplicity and elegance, and it seems to me it's a tool, and it should be used, but it should be used carefully and mindful that it doesn't necessarily have the whole truth. So that's one thought, a kind of stream of thoughts around data. Second one is kind of unapologetically plagiarising a very good graphic from the King's Fund's Population Health Management Report of yesterday, which I think puts this rather nicely. It says that population health management has 4 pillars, one of which is about a focus on the wider determinants of health and well-being, the kind of Marmot agenda, which is primarily not about healthcare. It's about how people live their lives and their behaviours and the extent to which these might be influenceable. It's about a place-based approach and understanding the particular characteristics, both needs but also strengths of different communities and thinking in a place-based way. And then finally, it's about trying to get an integrated health and care system. Not everybody needs everything to be integrated. I agree with that, Steve. But I think in general the systems need to join up better, even for people who are not in the kind of most complex apex of the triangle. And there's something about the critique of the King's Fund is that we have a system that doesn't give equal weight to those 4 pillars. In particular, it neglects the wider determinants of health, and it's still very unsophisticated in understanding the drivers of behaviour and how they can be influenced. And I think the NHS is a good example of a system that often sends mixed messages. Don't go to your GP, go to your pharmacist, because it's probably just a minor illness. In parentheses, how do I know it's a minor illness? That's a retrospective judgment. Or, got any worrying symptoms, go to your GP. The NHS is replete with examples of both those kinds of signposting. It's not consistent. And there's a lot of exhortation and telling. Take more responsibility. Go here, go there, don't go there. These are exhortations that are not informed by even the basics of behavioural psychology, and yet we've got lots of experts in academia and in government who could help the NHS get much better at modifying and encouraging people to change their behaviour. Probably the best example of where there's unrealised potential there is in all the work around health coaching and supported self-management, where there's a combination of a better, more joined up offer of care together with helping people change their own behaviour so that they can live a more healthy life, while not forgetting the social and economic determinants that constrain the choices that people have. So I like the kind of holistic approach to thinking about wider determinants, thinking about communities and places, thinking about how we use those underpinning elements to create a health and care system that generally joins together. And my third strand of thought about how to get from population to people is to think about it through the lens of engaging with people. These 6 principles for engaging people and communities was something that was developed by a committee that I chaired for a couple of years called the People and Communities Board, and its job was to help support the implementation of what at that point was called Chapter 2 of the NHS 5-year forward view, which was the stuff all about people and communities and about engagement. So the People and Communities Board of blessed memory did a number of pieces of work, including working with some of the what are they called now? This is a little bit of historical stuff. They were, it's gone completely out of my head, but they were absolutely cutting edge at the time until they no longer were, and they were in the dustbin of history. And they were the vanguards, that's it, the vanguard areas. Who remembers vanguards? Who's in a vanguard? Who's in a place that was a vanguard? Are you still a vanguard? You're not now, you're probably part of an integrated care system, or, yeah. For me, the vanguards are a very good example of how we're not very good at seeing things through. I thought a lot of really fantastic work was done in the vanguards, and they wanted help. Some of them wanted help with how do we turn the vision in Chapter 2, which is all about changing the relationship between the system and the citizen, into actionable things. So we created these 6 principles. In fact, we did it in tandem with them. And I think they're a good reminder that engaging people is multifaceted. It's about how people are engaged in decisions about their own care and treatment, all the way through to thinking about inequalities and communities, the role of the voluntary sector. This doesn't even include things like asset-based community development and thinking about how to strengthen communities, not necessarily an exclusive health focus, but in the expectation that strengthened communities are more likely to be health-creating communities. So there's, but the common thread is relating to people in a different way, removing paternalism, removing people standing on professional pedestals, a collaborative, inclusive approach that's focused on how can we have a different relationship with all the people in our patch, that's mutual, that's respectful, that's inclusive, and that leads to really cool stuff that at least in part has been co-created by those communities themselves. So for me, engagement is a thread that runs through all of this and is a good link between population health management and person-centred care. I can see out of the corner of my eye Nigel is looking at his watch. If you had a yellow card, would you be holding it up?
No, you're not on yellow yet.
Okay.
Yes.
You can be assertive with me because I'm very good at ignoring all signals and just carry.
Too much. Carry on. I'll get the time back.
Okay. Right.
I've no idea.
Well, look, I'm nearly finished. You'd be glad to know. Final thoughts. I can't remember what they are, so I'm going to have to peer around again. Yes, it's kind of, I've said this already. So, of course, population health management, a term I'm slightly uncomfortable with for all the reasons that you now know, has got lots of technical sophistication in it, and it could be more sophisticated, and it could be done better, I think. It could embrace different categories and different kinds of data and generate even better intelligence, in my view. But that's for discussion, I think. But fundamentally, it's still a values-based exercise because it's based on what are who decides that they sit above the population, and who is the population, and what the goals are. That's a moral exercise, and in my personal view, it's one that is better constructed in collaboration with the communities that we're trying to serve, rather than sitting above it. But you can't escape the kind of the moral question and the values question. In my view, the goals and values matter. Population segments are fun, interesting, clever, but they are abstractions. They're all different ways of seeing the world in order to be able to do something. They're intellectual abstractions. They're only useful if we do something useful with them. They're as good as the outcomes that they deliver. And if they're the wrong segments, there's the danger that we end up delivering the wrong outcomes or ignoring things that actually would be a higher priority if we'd known about them. But people and communities are real. You can talk to people. You can engage them. There's nothing to stop you finding out more just by talking. So for me, there's a sort of sweet spot where you bring together data and cleverness in analysing it with engagement, the clever analytical stuff and the relationship stuff, talking to people and looking at the data. Both are necessary, and it's about getting the right balance. And I think, to my mind, that's hard. It's what used to be called world-class commissioning. It's showing my age now. And it's difficult to do. And I think it's important to recognise that the people who are now going to be doing this, who are the people who would formerly be commissioners in CCGs but are now probably increasingly going to be commissioners in ICSs and all the other alphabet soups, but still got the same problem, trying to work out what the problem is and then working out what the solution is and then trying to kind of put together some solution. It's difficult stuff. It takes skill, it takes resource, it takes persistence, it takes trust building, it takes time, and all of those things are in short supply in the NHS. So I think that's one of the reasons why we haven't made more progress with this stuff, actually. But you can talk to people in the meantime. Engagement brings data and analytics to life. I've kind of made that point already. Yes, the voluntary sector, my sector, does straddle a continuum all the way from prevention to treatment, from population health management to engaging with people in their care. We've had some really good examples today of the role of the sector. Voluntarism, ironically and paradoxically, doesn't come for free. It needs to be organised. It needs to be resourced. And those of you in the statutory sector who are engaging with the voluntary sector, my little plug, don't forget that their sustainability can often be on a knife edge. And don't assume their support, because they might disappear all of a sudden because they've run out of resources and money and need to close down. So having a sustainable business model for the third sector parts of an integrated care system is really vital. It's something that should be given conscious thought to in the commissioning world. There you go. Thank you. Thank you for your attention. I'm looking forward to the panel discussion.
For more information and insights, visit our website, sollis.co.uk.